Okay, let's begin. Welcome. If I haven't already received your assignment from last week, both of those research questions, I can collect those now. I'll send those nice links. Okay, I believe I got that just in the yeah, I'm not sure. This email. Thank you. Anybody else? Okay, so you still have till the end of the day today, right there. So all you have to do is just read and then answer the questions. So this one's about abdominal bracing, and this one is about the role of the gluteus medius. So you can learn something about those topics.
I like that the one about abdominal bracing had your study in there.
It is? One of mine? Okay. I'll take it. Yeah. I've done a few. So what's the condition with the gluteus medius when the pelvis is tipped to the side of the support leg? Remember that? And Dellenberg. Yeah, so you want to remember that, I believe, for the next exam. So, speaking of the next exam, that's Wednesday. So, there is a study guide posted, so you can just look right there in that folder, pull it up. Take a moment, go through those bullet points on chapter 6. Let me know, is there any items that I can clarify or help with?
So I was confused on the tennis elbow and golfer's elbow. I believe it said tennis elbow was the outside.
That's correct.
So the lateral epicondyle, golfer's medial. For some reason, I always would think golfing would be more on the outside, but
I believe it'd be the inside arm, medial side of the inside arm.
golfers.
Yeah. Yep. So the flexor tendons. Sometimes it's called little league elbow. Golfer's elbow, little league elbow. Flexor tendons there's 5 out of 6 of your wrist flexors attached there, and then 4 out of 6 of your wrist extensors attached to the lateral epicondyle on the other side. So that's about it. That's about it for that one, the extent of what you'll need to know. Good on chapter 6. So you will need to know your anatomical terms, but there will be a word bank. So how about chapter 7?
So the question I have is, so we don't necessarily need to know all the specific intrinsic muscles, but it's listed under like the innervated stuff on the PowerPoint. So do you still want us to know those specific ones for the nerves?
For the nerves, yes.
Okay.
For the nerves, yes. Take a moment, just go over that. So word banks, but you still have to know where to put those terms. How about chapter 8? Take a look there. Take a minute, let's go through. Any questions? Okay, you feel good at this point. So if you have a question that comes up as you're diving in to this in the next couple days, send me an email. Might be 4 in the morning when I reply, but I will reply. Okay, so course outline. Exam 3, we will finish chapter 9 today. You don't have a whole lot to finish on that, so I have a nice activity for you to help review lower extremity joint actions, muscle actions, prime movers. Wednesday, exam 3. Monday, November 21st, we'll start chapter 10. And when you come back, we'll finish chapter 10. So in the middle there, we have the Thanksgiving holiday, shrunken spinal column. We don't do chapter 12 because you already know movement analysis, so it's covered that pretty well. And then Monday, December 12th, 8 o'clock here will be your final exam, so 9, 10, and 11. So it's not comprehensive, just the last 3 chapters. So that's good. Early on in finals week, right? Get it done first thing on that Monday. So, good. Okay. All right, so dive back in chapter 9. So what's the functional classification of the knee joint? It's a little bit different than the elbow. What is it mostly? It's mostly a hinge joint, gangrenous type joint. But what is different about the knee joint versus the elbow? Yeah. Yeah, so it has rotation. So especially in a closed chain position, it will rotate. So what does that mean, closed chain? So when you say that about a movement closed chain, what does that mean? Yes, so feet are fixed. So any type of closed chain, squat type lunge movement. Okay. So it's important to keep straight how the knee actually rotates. As the knee begins to flex, there is external rotation of the femur relative to the tibia. And then as we ascend and the knee is extending, at the final phase of extension, the femur internally rotates, the tibia externally rotates. So there's a slide in there about that, and so you'll need to keep those two things straight. So there is a little bit of rotation at the knee joint, which is why the Q angle is so important. If you look at the anatomy of the femur, the medial condyle of the femur is larger to account for the Q angle. So to keep the same amount of pressure on the tibial receptacles, the medial condyle has to be just a little bit larger and extend more distally versus the lateral condyle. So the knee joint is probably one of the most complicated joints in the body. It has supportive ligaments, internal and external through the joint capsule. The one that we hear a lot about, if you every Monday morning, after the Sunday football, it's bottom line ESPN, who's out with an ACL injury. So what's the function of the ACL? Yes, it stabilizes the knee anteriorly. So it prevents the tibia from sliding forward relative to the femur. So another way to think about it is it prevents the knee from hyperextending. So when we hyperextend the knee, that means the tibia is moving too far forward underneath the femur. And so we stressed out those soft tissues beyond what they're structurally capable of handling, and that's when we have a sprain in a ligament. So different degrees of sprains, first, second, and third degree sprain. Third degree is the worst. But we have advanced surgical techniques that enable quick rehabilitation, at least compared with decades ago, where it was much more invasive, probably ended a lot of athletes' careers. But now it's a little less invasive, and athletes are able to come back and perform 100% of what they were before. So the Q angle describes the intersection of two lines. So the first line goes from the anterior superior iliac spine. So as we've studied the pelvis, that's this point right here, and that's easily palpable just around the crest of ilium, and then you come to this terminal point, and so that's the first mark. Hey, Brian, that's the first mark for the ASIS, anterior superior iliac spine. And so from there through the center of the patella, and then we have another line that is vertical through the center of the patella. And so the line of action of the patellar tendon through the center of the patella, ending here at the tibial tuberosity. So what we can see from this is that the wider the pelvis, the more pronounced the Q angle will be. So a wider pelvis would mean that this outside line here would begin somewhere out here, and so that intersection would create a greater angle. So as far as risk of ACL sprains goes, the Q angle is a significant risk factor. So higher Q angles tend to be associated with greater valgus type forces at the knee joint, which makes muscle conditioning really important. So trying to balance the strength between all the muscles that control the hip and control the knee, especially trying to balance the strength between the quadriceps and hamstrings group and so on. Very important. The other factor, we really can't modify the Q angle. We also can't modify the intercondylar notch. So if you look on the bottom of the femur, there's a notch between the medial and lateral condyles. And that notch is where the cruciate ligaments cross. And so that notch tends to be more narrow in some people. So those ligaments have less space, so to speak. So there could be more friction there with the condyles. So in summary, we have factors that we can't modify. So the intercondylar space, the Q angle, but we do have muscle conditioning that we can modify. So trying to create balance in muscles that control the hip and the knee joint. So as you read that study by Presswood and you went through that, was it the Jonda system, where it was graded 1 through 5 on level of function of the gluteus medius. Sometimes these rehab articles are directed more towards a clinical population, and it can be hard to visualize as a young, healthy college person, not being able to even hold your leg up from a sideline position. But if you go out and become a physical therapist, you'll definitely encounter people that struggle with that. So there's a lot of assessments available to assess function. One of the limitations of the static assessment was, do you remember what was talked about in the article? Just a static stance. So how often are athletes just in a static stance? So they move, right? So being able to maintain pelvic stability in a dynamic scenario could be more important than just a static scenario. So you can guarantee that if there's problems with static, there's probably also issues with dynamic. So what are some numbers for the Q angle? So if we were to measure this, 15 degrees or less in males, 20 degrees or less in females. So on average, due to differences in the width of the pelvis, okay, females will have a greater Q angle. So it also turns out that if you look at a large population of female athletes and a large population of male athletes, there's about a 7 times greater incidence of ACL tears, probably related to differences in anatomy. So very important that we pay attention to conditioning and balance in those muscles, especially single leg stance. Single leg stance is very important. So all athletes ought to be able to do a single leg squat. So that's kind of a baseline. You ought to be able to support your body weight and squat on one leg. That's a good thing to reduce risk. Okay. So Q angle is related to those valgus type forces at the knee joint. Okay, so getting into muscles. So the knee joint has fewer muscles than some of the other chapters that we've studied. Don't neglect for chapter 8 studying those 7 muscles that act at both the hip and the knee, because I'll ask you to list those on the exam with actions at both the hip and knee. So remember those 7 muscles. The reason 2 joint muscles are interesting is because they can do one action or the other, but not both to the greatest extent at the same time. So if a muscle is trying to contract and do the greatest amount of movement at 2 joints at the same time, what do we call that? What type of insufficiency is that? Active insufficiency. So think about the rectus femoris. It's a flexor of the hip and extensor of the knee joint. So those are 2 open chain type functions, flexor of the hip and extensor of the knee joint. So a good example of active insufficiency would be comparing old school leg extension models from, say, the 1970s. The first selectorized resistance machines came out in the 1970s with Arthur Jones, inventor of Nautilus. And then all of the other different brands followed that. But 1970s was the first we had anything other than just free weights. And it turns out, guess what is best after all these years? Free weights. So, yeah. So just the good old-fashioned free weights is the best. But the machines are really interesting, and Arthur Jones was a very creative person. He tried to match the strength curve for a specific muscle, so that at some points in the range of motion it was more difficult to move the weight. At other points it was easier. So very creative, fascinating how he designed this equipment. If you look at the old school leg extension models, the seat is more upright. So upright, the hip is at a 90-degree angle. So based on what we know about active insufficiency, why would that be a problem? If you're sitting in a nice, tall, upright position, the rectus femoris is going to be working from the hip to keep you in that nice, upright position. And then what are you doing at the knee joint? You're extending, so you've got that and that at the same time. So we run into active insufficiency of the rectus femoris. So modern leg extension machines, have you noticed how the back pad is designed? It's a little more reclined, right? So you're opening up the hip joint a little more. In other words, you're lengthening the rectus femoris over its attachment at the hip, which enables the rectus femoris to be more effective in extending the knee. So, yeah, things evolve over time, and we tend to get better at designing things. Just like any other field, things become better over time. So anterior pelvic rotation, that would have to do with a closed chain position. So the lumbopelvic segment rotating about the femoral heads. So if the femoral heads are fixed and we have bilateral activation of the rectus femoris, that's going to, and our abdominals are braced, right? That makes the pelvis and the lumbar spine, which attaches to it, one segment. So the lumbopelvic segment that then rotates about the femoral head. So it can tilt the pelvis forward as well. Okay, so the rectus femoris is the only muscle of the quadriceps group that has action at both the hip and the knee joint. The other 3, vastus lateralis, vastus intermedius, vastus medialis, they all just have action at the knee, so extending the knee joint. So it turns out it's really, if you look into EMG research and everything that's been done over the years, you can kind of get a good picture of how an open chain exercise like the leg extension affects quadricep activation versus a closed chain exercise like a squat, because there are differences. So as we've looked at the mind-muscle connection in lab, you should recognize that different regions of a muscle can be activated more or less by how you do the movement, isn't that the beauty of resistance training? You have all these different variations to more fully develop a given muscle. So the way that the nervous system activates a muscle is different with just slight amounts of variation in your technique. So it works the same way here. With a squat, you get very little activation of the rectus femoris, probably due to its attachment at the hip joint. So the squat involves hip extension or hip flexion concentrically. So you're standing up, so it would be hip extension, right? So we're not actively flexing the hip. When we descend in a squat, we're controlling hip flexion, but we're not causing hip flexion. And then during the ascent, we actively promote extension of the hip. So we're taking the rectus femoris pretty much out of the movement. So if you look at any of the EMG research on squats, the emphasis is definitely more on the vastus lateralis and vastus medialis. So then you take a look at the EMG research on leg extensions, guess what you find, especially if you have a nice reclined seat. It's more rectus femoris and lesser development of the vasti muscles on each side. To take this a little bit further, what's really an interesting concept is the way that muscles develop over time is connected to how muscles are activated. So if you look at a leg extension exercise conducted over a period of time, it's the rectus femoris that gains the most size. If you look at a squat exercise that's repeated over time, over 8, 12 weeks or so, it's the vasti muscles that achieve the greatest gain in size. So different exercises result in different amounts of hypertrophy for different portions of the quadriceps. So I even saw one study recently that looked at the distal versus proximal part of the quadriceps for a knee extension. And the degree of hypertrophy wasn't the same from the hip through the knee joint. Guess where most of the hypertrophy was for the knee extension? Closer to the knee joint. So isn't that interesting? A muscle is not going to make the same changes all the way from the origin to the insertion. So one portion of a muscle may get more of a remodeling effect or more of a hypertrophy effect versus another portion, which is why whatever we decide to do, we need to do multiple movements for the same muscle. We also need to do full range. So multiple movements that target a given muscle, and we also need to do full range. That way, we're getting changes all the way from the origin to the insertion point. So vastus intermedius, this is one that we can't palpate because the rectus femoris is over the top. This one has a huge amount of tendon. You can see all the way up here into the muscle where we have this broad aponeuroses, and then coming, it's pretty much a straight line angle down to the tibial tuberosity. Okay, vastus medialis. So that's that teardrop shaped muscle there on the medial side. Notice how the fibers kind of have an oblique angle. So the fibers or cells are bundled together in these fascicles that kind of have an angle in their attachment all the way down the medial side of the femur, and then insert with the other quadricep muscles on the patella, continuing down to the tibial tuberosity. So one of the issues that we talked about with knee problems is unequal force on the patella. So you've got the vastus medialis that is pulling and creates a force vector up and to the medial side, vastus lateralis up and to the lateral side. Okay, so that can really create problems if we have muscle imbalances. So remember there was that study that looked at how to improve activation of the vastus medialis. So that can be an issue in more of a clinical type setting, trying to get this muscle to activate to match the pull of the vastus lateralis. Okay, semitendinosus. This one is pretty easy to measure with surface electromyography because it's on the medial side and it's closest to the skin surface. So this muscle you can see semitendinosus. When I think of that muscle, I think of a muscle that has a very pronounced tendon. And so you can see here, this is the one right on top, and you can see it has this great big long tendon, comes down and attaches to the medial condyle of the tibia, just below there. It also shares a common insertion with two other muscles. Do you remember the pes anserinus? What are the other two muscles that share that insertion with the sartorius and gracilis? So this won't be on this coming exam, but will be on the next one. So remember, was it on the study guide? Well, regardless, so I'll give it to you. So if it's on this exam or the next, it's going to be the sartorius, the gracilis, and the semitendinosus. So the sartorius and gracilis are the two other muscles that share a common insertion. So sartorius, gracilis, semitendinosus. So flexion of the knee joint. Okay, so of course it's one of the hamstrings. Extension of the hip. So that would be more of a closed chain function. So again, taking the lumbopelvic segment with the feet fixed, which means the femur, the femoral heads are fixed, and then we're getting that rotation about the fixed femoral heads. So extension of the hip is a closed chain function of the hamstring. So your RDLs and so on. Anything that involves deadlifts, anything that involves extension of the hip. Internal rotation of the knee. So by virtue of its attachment on the medial side, it contributes to that. So as you're sitting there, if you'd be willing, just put your fingers on either your left or right tibial tuberosity. And so your knee joints are already flexed. If they're not, flex your knee joint about 90 degrees. And all I want you to do is rotate your knee in and rotate your knee out. See how that rotates out? So you get quite a bit more external rotation of the tibia versus internal rotation, but you can see you don't have that same movement with the elbow. So you're sitting here, you got supination and pronation, right? But you don't have that turning effect of the actual elbow joint like you do with the knee joint. So you notice the rotation more when the knee joint is flexed. So take home message, if you need to place emphasis on the semitendinosus and semimembranosus, which is just underneath the semitendinosus, you can do your leg curls with your knee joints internally rotated. So think about that for a moment. You're doing a leg curl, knee joints are internally rotated. That should engage those semi-muscles on the medial side a little bit more. That'd be a good project. Good senior thesis to look at that. Another closed chain function, posterior pelvic rotation, so tipping the pelvis back. Okay, semimembranosus, same thing. This is a muscle that we can't measure via electromyography. because it is underneath the semitendinosus. So generally we don't see that one in EMG research. Doesn't mean it doesn't. Somebody hasn't tried and published it, but it's pretty hard to get. Okay, biceps femoris. So biceps means two, right? Long head and a short head. The short head is more lateral and doesn't cross the hip joint. So that's a good test question. So which of the bicep femoral heads does not cross the hip? It'd be the short head. So that's the short head right here that has its origin about halfway down the linea aspera. So that's this bony ridge of tissue here. This is the short head, and then the long head is up here. So all of your hamstring muscles, with the exception of that short head, had their attachment up here. What's this process right here called? This roughened part of the yes, ischial tuberosity is right. So sometimes that's called the sit bone. So that's where we need to get our foam rollers out at night, right? You're watching your favorite TV show and you need to roll those glutes like crazy, right? That's where we tend to get tight because we're sitting on those tendons all day long. So it makes sense that those muscles would tend to be overactivated. We need to calm them down and so they're not pulling on our pelvis all the time. Okay, popliteus. Popliteus. Interesting name for a muscle. I don't know who thought of that. But it's a weak flexor of the knee joint. Now, remember, muscles generally pull from the origin towards the insertion, or from the insertion towards the origin. From the insertion towards the origin. So if we look, the origin is here at the lateral condyle of the femur. The insertion is here on the medial portion of the tibia. So it's going to pull from right here towards this direction. And what that does is it tends to rotate the tibia medially. As it pulls up this way, the tibia is going to turn and rotate internally. So it's just a small muscle under there that probably serves more of a stabilizing function versus a large dynamic role like the other hamstrings do. Okay, so do you have any questions? Anything come up in your mind as you thought about the study guide? Okay. All right, so I do have a class activity today. My voice is starting to wear out here. So let me pass this out and I'll explain it. So remember in lab 4 we did upper extremity skill analysis. Okay, so now we're going down to the lower extremity. So you have 4 parts. You have the hip, you have the knee, the ankle, and the foot. All right, so it's the same process. You're going to work in groups of 2. You're going to look at preparation, movement, and follow-through phases. So you might be wondering at this point, well, how do I know which leg? Well, I provided that, suggested that. So in parentheses there in bold for the baseball pitch, it's going to be the left hip that you're analyzing for a right-handed pitcher. For a football punt, it's going to be a right-footed kicker, so you're planting with the left, kicking with the right. For a softball pitch, it's going to be the left hip for a right-handed pitcher. For a soccer pass, it's going to be planting with the right, kicking with the left. So left foot, dominant kicker. Bowling ball delivery, it's going to be the right hip for a right-handed delivery. Basketball fake and first step opposite direction. You're going to be faking right and going left. Okay, so you'll have 2 tables a little bit different than what we did for upper extremity where there was more joints. So you've got 2 pages. So you'll list your skill. You see the joint in the left column, hip, knee, ankle, foot. Now for the foot, it's going to be inversion versus eversion. So don't mistake that for action at the ankle joint. So inversion and eversion. Does everybody know what inversion is? So turning the sole of the foot in versus eversion, turning the sole of the foot out. So that takes place at joints that are below the true ankle joint. So I want you to look at that separately. So all 3 of those phases with muscles, muscle actions, you're looking at the position of the limb at the end of the preparatory, movement, and follow-through phases. So don't overly complicate it, just a single lower extremity, like you see up here highlighted in parentheses. Pay attention to subtleties. So we've talked a lot about if your feet are planted, the femurs are fixed, the lumbopelvic segment will rotate, which creates internal and external rotation of the hip, right? So if you're batting in baseball, there would be fixed femur in the stance, and then rotation of the pelvis about the fixed femoral head. So I want you to pay a little more attention to subtleties in internal and external rotation. Foot position, are we slightly inverted? Are we slightly everted? Okay, so sometimes inversion is equated with supination of the foot. Eversion is equated with pronation of the foot. So I think that about covers it. Do you have any questions? So why don't we work the rest of the time today? Pair up with someone. Use your movement and muscle directory. And let's work through this. Give you some participation points. Please let me know if there's anything on your study guide